Hello and welcome everyone to this session on case-based scenarios in medicine part 1. My name is Dr. Jhanvi and I am going to be holding a quiz for you all since the NEET PG exam is close to now our preparation even though the exam has been postponed. I think it's high time that you all start solving more and more questions and see where your preparation lies. So first of all, I want you guys to leave a thumbs up in the chat box if you're able to see me and hear me well. All right, so I can see that the streaming is absolutely fine and we are going to go ahead with the class. So I will be able to see your comments in the chat box. So whatever questions I ask, I want you guys to answer in the chat box and then we'll discuss the question and the answer. All right. So with that, let's begin our class for today. Welcome to Unacademy. I have done my MBBS and MD in anesthesiology, and this is the Telegram channel where you will get the links to all our classes. So this is the Telegram ID. Let's crack NEET PG. I highly recommend all of you all to join it so that you are able to see the classes and also get a notification about them. Now, for all of y'all, we have an All India mock test of NEET PG 2022 on 26th of February at 9 a.m. This is the final chance before the exam to be able to evaluate how well you have prepared as compared to others. It's a free mock test. You can use the code NPG10 to enroll into it, and I highly recommend you guys to join the mock test so that you're able to find out how good your preparation is and how much more you need to put in the last couple of months. The Plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators. The Iconic subscription is a partnership between Unacademy and Ladder, which will help you get Ladder question bank and Ladder videos along with the Unacademy live classes. And these are our FMGE toppers 2021. We also have many test series. We have the educator curated test series, which is subject wise tests by the best educators. So the one that I have curated for anesthesia is going to be on the 18th of Feb. I will send the link to all of you all on the NEET PG Let's Crack NEET PG channel on Telegram. And in our special classes on the platform, you can get access to free live classes along with you will be able to download the PDF at the end of it. These are the batches that are going on right now. The Target Next 2023 subject wise batch, the NEET PG 2022 All Educator Revision batch. It's a 3-month batch, and this one is the one that I highly recommend for your final revision before the exam. So if you've missed out on any subject, you can cover it up in this batch. And the Focus FMG batch for 2022, and the prices of the NEET PG Plus subscription have now drastically dropped. So you all can see the revised prices. We also have an offer on the Iconic subscription, which is now highly discounted. And if on top of that you want more discount, you can use my code Dr.Jhanvi Live, which will help you get an extra 10% discount over and above whatever is the discounted rates. So good morning everyone. The first question that I have for you guys is this. A 55-year-old man has quadriplegia after undergoing suboccipital craniotomy in the sitting position for the treatment of acoustic neuroma. Which of the following is the most likely cause? Venous air embolism, jugular venous obstruction, raised intracranial pressure, cervical cord compression. So I'm looking forward to your answers in the chat box, everyone. So this is our first case-based scenario for today. Can anyone answer? What is it? Okay, so Meghna is saying answer is venous air embolism. Any other answers? Mansi is also saying A. Quickly guys, so many of y'all are there online. I want you all to quickly answer this. Giri Chaitanya A. Okay, till now whoever has answered A is the incorrect answer. All of y'all are answering A because that is the only thing that y'all have learned. But all of y'all are wrong. Any other answers? If someone chooses some other option, I can then move on to the explanation. Very good, Akash. So Akash is the only one who has answered it correctly. So this is because of cervical cord compression. So now I know that most of you all must be thinking, "Arey ma'am, sitting position and something is happening." So sitting position may the only thing that we have learned is there is venous air embolism. I agree with you all that venous air embolism does happen in sitting position, but venous air embolism does not lead to quadriplegia. Look at the symptoms that they are talking about over here. The patient is having quadriplegia. Quadriplegia means upper limb and lower limb, both the power is gone. Okay. So if the power is gone, that means there is something that is wrong with the spinal cord, because the spinal nerves are responsible for supplying all these areas. Correct. So what is wrong with the spinal cord or the spinal nerves? Now there you are doing a suboccipital craniotomy. So basically, your head must have been in the flex position, and as a result of this, your cervical cord must have been stretched. So excessive stretching of the cervical cord or injury, direct injury to the cervical cord could have caused this quadriplegia in the patient. So look at what are the symptoms of the patient and then go for the answer. Okay. So if you are looking at something that is related neurologically, the cause of it also has to be neurological. Now, how would the other things have presented? So if they are, this was the thing that they were trying to confuse you by saying sitting position. Okay. Now have a look at this. How does venous air embolism present? So everyone knows whenever you have venous air embolism, the air that is there, it will go into the heart, correct? And where does the air go? The air goes into the right side of the heart and it blocks the right ventricle. So as a result of this, the blood from the right ventricle is not able to enter into the pulmonary artery. So what do you get whenever there is venous air embolism? Because the blood is not entering the pulmonary artery, you have hypotension. And since from the pulmonary artery, the blood cannot go to the lungs, it cannot pick up oxygen from the lungs. So you will have hypoxia or desaturation in the patient. Okay. So your venous air embolism will present with sudden fall in blood pressure, sudden hypoxia or desaturation, and slowly it will lead to a cardiac arrest in the patient. So these are the symptoms that a patient of venous air embolism will present with. So I agree that in sitting position you can have VAE, but this is not a case scenario of VAE. Now, what happens if you have jugular venous obstructions? Often when you move your neck, aisa or twist and turn your neck, what happens is that your jugular veins get compressed, or if the neck is like this. Okay. So in case of jugular venous obstruction, the venous blood flow from the head and neck area to the heart will be stopped. So there will be engorgement of the head and neck veins, and that is why you will have plethora or swelling of the face. Okay. And you will also have cerebral edema because the veins are all dilated. Okay. So that is how jugular venous obstruction will present. And raised ICP signs and symptoms, so you all know there can be headache, there can be vomiting in the patients post-operatively. So that will give you a clue that that is raised ICP. Okay. So look at what is the presentation and then give the answer. Don't just think कि अरे sitting position बोला है तो answer will definitely just be venous air embolism. Okay. So with that, we move on to our next question. During a CPCR situation, the nurse is unable to find an IV access. The doctor in charge directs her to give drugs diluted in saline through the endotracheal tube. Which of these life-saving drugs can be given through the endotracheal tube? Atropine, adrenaline, lignocaine, or all of the above? चलो बताओ इसका आंसर. Okay, so PSK is saying adrenaline. मेघना, okay. ऐसा होता है कि one person gives one answer and then everyone else just follows suit. But remember, exam में you're not going to be able to see the answers of other people. So the answer is wrong, guys. Adrenaline is wrong. What are they asking you? Whenever you have a case-based scenario, you have to pay good attention to the last line, to what are they asking you. So they are asking you which life-saving drugs can be given through endotracheal tube. Okay. They are not asking you what is the drug that you are going to give. They are asking you which drugs can be given through endotracheal tube. Very good, Mansi. So the answer is all of the above. So they are simply asking you which drug can you give through endotracheal tube, not which one do you want to give. Okay. So how, if you don't have an IV line, What you do is that you take the life-saving drug. It may be adrenaline, atropine, lignocaine, whatever, depending on what the patient is suffering from. If the patient is having severe bradycardia, you will give atropine. If the patient is completely arrested, cardiac arrest, heart has stopped working, you will give adrenaline. If the patient is having any arrhythmias, especially ventricular arrhythmias, you can give lignocaine. Okay. So what you do is take a little bit of the drug, how much ever is the dose indicated, and mix it with 20 ml of saline, and then you give it directly into the endotracheal tube. When you give it into the endotracheal tube, it will go through the trachea, it will go into the bronchus, and then over here it goes into the lungs. Okay, so your drug is reaching the lungs. Now from the lungs you have something which is called as alveolo-capillary barrier. Okay, so the drug will enter from the lungs, from the alveolo-capillary barrier into the pulmonary veins, and from the pulmonary veins the drug will reach your heart, and that is where the drug will act on your heart. Okay, so that is one of the ways of giving drugs if you are unable to find an IV access. Okay, so all these three drugs, remember, you can give all the drugs. That's how I remember. We can give all drugs through endotracheal tube. A for adrenaline, A for atropine, and L for lignocaine. Now, can anyone tell me what are the dosages of these drugs whenever you give it in CPCR situation? You should know the dose of these three drugs, because they are very, very important in CPR. So, can anyone tell me the dose of atropine, dose of adrenaline, dose of lignocaine? Anyone, do you know the doses of all of these drugs? Thank you, Giri Chaitanya. We have a series of these case-based scenarios this month for the remaining days of the month on YouTube. So we have another session at 12 o'clock today and 5 o'clock today. Alright, so atropine, I'll tell you the dose is 0.6 mg. That is a bolus dose. Okay, I'm not giving you a per kg dose. That is a bolus dose. Then adrenaline, you give it as bolus as 1 mg, and lignocaine, you give it as 1 to 1.5 mg per kg. Okay, so that is the dose of all these important drugs. This is very important, all three of them, CPR drugs, you should know the dosages. Now tell me, if there is no IV access, what is the next access that you can look for? Anyone, any idea? If you cannot find an IV access, how can you give the drugs? What are the other routes that you can give it through? One I have already given you as a part of this question. You can give it endotracheal. Any other access that you can give it from? Any other routes of administration of the drugs? Come on guys, don't be shy. You can answer. If you make mistakes over here, then only you will be confident for your exam. Meghna, central line is also an intravenous access only. You put central line through IJV or subclavian vein. So it is an intravenous access only. Yes, very good, Giri Chaitanya. So intraosseous is one of the accesses. Intraosseous is basically giving the drug into the bone marrow. So at the upper end of the tibia, that is the most common place where you can give intraosseous drugs. Nishi, yes, you're correct. Intranasal is one of the accesses, but not in CPR. That is for other drugs. Intranasal, especially for your nebulized drugs. Any other access? You all forgot your basic accesses. What about IM? Intramuscular access, है ना? So you can give IM, but it takes at least 5 to 10 minutes to act. It does not act immediately. Then some people say you can give intracardiac also. So directly just take the syringe and needle and push it into the heart, but that's not indicated anymore because it can cause cardiac tamponade. So that is seen only in that, what is that movie? Twilight movie, in which he gives intracardiac venom. Okay, yeah. Any other routes that you guys know of? All right. So these are the basic routes of access that you can give your drugs from. And this is what you need to remember for your exam. Okay. All right. Next question. After which surgery is this appliance used? So I am showing you the picture of the appliance. It's on the next page. Colostomy, loop ileostomy, ileal condyle, sigmoidostomy. This one. I'm just changing the question a little bit. After which surgery is this appliance not used? Okay. So this is the appliance that you guys need to see, and you have to tell me after which surgery is this appliance not used. Colostomy, loop ileostomy, ileal conduit, or sigmoidostomy? Giri Chaitanya, intraosseous in child is given at the upper end of the tibia. Okay, so can anyone tell me after which surgery is this appliance not used out of all of these surgeries? First of all, can you identify what is the appliance? Okay, so Meghna is saying it is not used after sigmoidostomy. Akash is saying after ileal conduit surgery. Any other answers? Yash is also saying D. Okay, first of all, can you guys tell me what is this? Alright, so let me tell you, this is nothing but a stoma bag. Okay, so this is a stoma bag. Now, this stoma bag collects what? There are two things that a stoma bag can collect. One is it can collect stools or it can collect urine. Okay, now how do you identify which bag collects what? So whenever you have this pouch like opening, na, this velcro ka pouch like opening, that means this collects stools. Okay, now if you have another stoma bag, I think I forgot to transfer the picture, so I'm extremely sorry about it, but that will basically have a narrower opening like this, and it has something to connect here to a Foley's Euro bag. Okay, so this is a narrower opening stoma bag which connects to a Euro bag, and that is the one that is used for collecting urine. Okay, so there are two types of stoma bags. You have one which collects stools and one which collects urine. So the one with the pouch, you just whenever the stools get collected during the day, the bag becomes full, you just open up the pouch opening, clear it out, and then you close the pouch opening again. On the other hand, whenever you have a bag which collects urine in it, it will have a narrower opening and it will collect the urine in the Euro bag. Okay, that is because urine comes much more often as compared to stools. So instead of the patient again and again every hour emptying the urostoma, what you do is just connect a Euro bag to it so that it continuously empties into it. All right, so this is called as a urostoma bag and this is a stool stoma bag. So whenever, in which surgery do we use a stool stoma bag? If you do a colostomy, yes. If you do a loop ileostomy, yes. Sigmoidostomy, yes. So anything related to the colon, in all of these we will use a pouch stoma bag to collect the stools. But ileal conduit surgery is done whenever you have CA of the urinary bladder. Okay, whenever you have CA of the urinary bladder, we do a surgery called as radical cystectomy ileal conduit. So what do you do in radical cystectomy over here? You remove this bladder. Okay, so I'll show you how. So those are your ureters draining into the urinary bladder. So since the bladder has a tumor in it, what do? You remove the bladder. Okay. Now, where will the ureters drain if you're removing the bladder? So then you take a loop of the ileum and you create an artificial bladder. Okay. So that is called as your ileal conduit. So here you're creating an artificial bladder. So this is called as radical cystectomy ileal conduit. Now, what is going to be there in this artificial bladder? There is going to be urine only in it. So what you connect to this is you create an ileostomy from this ileal conduit and you connect it to one of the urostomy bags that I told you about. Okay, so this surgery you do for collection of urine. Rest of the surgery is colostomy, loop ileostomy, sigmoidostomy. There will be collection of stools in the stoma bag. Okay, all right. Moving on to the next question. So Raju comes to the casualty with an acute pain in his lower abdomen. He is admitted, his vitals are noted, urine output is collected in the Foley's and is recorded. He has slight hematuria. What is the first investigation to be done to give you most of the required information? CT abdomen, X-ray abdomen, endoscopy or USG abdomen? Okay, so Akash and Staphylococcus and Giri Chaitanya, all of you all are saying D. Nimesh is also saying D. So out of all the questions that you all have answered till now, this is the first question everyone is answering correctly. Okay. So what are they saying? There is acute pain in his lower abdomen. What all is there in the lower abdomen? If it's a male, then you can have some problem in the bladder, or you can have some problem in the rectum, or in the colon. Okay, so if it is a female, then you can also include the obstetric organs like your uterus or ovaries. Okay, so he is admitted, vitals are noted, and urine output is collected in the Foley's. Now, what is the catchphrase over here? They have told you there is slight hematuria. So there is something wrong with the urinary bladder. So if you want to find out whatever is wrong with the urinary bladder, the first investigation is the one that is always easily available everywhere, and it is quick to perform, and it gives most of the information. Okay, so ultrasound everywhere for the bladder is the first investigation because it's easy to do, it's quick to perform, and it will give you most of the answers. So the answer over here is ultrasound abdomen. Okay, endoscopy will be done if there is any kind of esophageal or upper GI tract problem. X-ray abdomen does not give you much of an idea unless there is presence of a stone. Okay, but even a stone can be found out. You have to have a radio opaque stone, and even a stone can be better found out on USG. And CT abdomen, yes, it's a great investigation, but it is not the first investigation. Okay, remember, we are still in a resource limited country. We will not get CT available everywhere. It's also very costly, and people don't like to go for CT as the first investigation. Okay. All right. Now, what is the mass that is present in the bladder? Bladder tumor, Foley's bulb, bladder stone, or hydrated cyst? So I want you guys to tell me, I'm marking with the arrow over here. I want you to tell me what is that mass that you see in the bladder. Okay, very good. So all of you who have answered it as Foley's bulb, absolutely correct. That is a very good and a very calculated answer. Absolutely right, that is Foley's bulb. So can you tell me the rim of that picture that you can see over here? The rim is hyperechoic. You can see it is white, white, white. And in the middle, you can see that it is translucent, or it is hypoechoic. Okay, so what is there in the middle that is making it look black? What is there in the middle that is making it look black? Yes, very good, Yash Goel. So, for how to identify that it is the bulb of the Foley's, I told you over here that Foley's was put and urine output was recorded. Okay. Now, what is filled over here? It is filled with water or saline, whatever you fill the Foley's bulb with, and that's why beach ka part that is there, it is looking darker in color because of presence of the fluid. Okay. Now, how do we rule out the other things? If you want to know how to rule out the other options over here, so you look at the bladder tumor. Okay, so bladder tumor is something that needs to arise from the bladder. The most common place where bladder tumor arise, transitional cell carcinoma, is from the trigone, correct? So it has to arise from some wall of the bladder. So can you see over here, there is something? This could possibly be a bladder tumor, but not this free floating thing. The one that is above is free floating. It cannot be a tumor if it is floating in the urinary bladder. Okay. So even this thing over here, the one that is, it looks like it's arising from the wall, could be a bladder tumor. But the arrow was marked towards the other thing. Okay. Bladder stone. How do you identify bladder stone? Again, bladder stone will not float in the bladder. Bladder stone will also come and settle down somewhere. Okay. It will, because of gravity, it will settle down in the bladder. So that's how you come up with the answer of bladder stone. Okay, and also behind the stone you will be able to see something called as acoustic shadow. So because the stone is opaque, beyond it you will be able to see everything dark because the rays of the ultrasound will not go through it. And hydrated cyst, again, if you have a hydrated cyst, it will not float in the bladder like that. It will arise from some wall of the bladder, or it will settle down on the bottom of the bladder. Okay, because of the gravity. So it's not going to float around. So if something is floating in the bladder, that means it's nothing but Foley's bulb. Okay, so this was a trick question for you all to identify. Now moving on to our next question. A 50-year-old chronic alcoholic male with liver cirrhosis comes to the casualty disoriented and breathless due to abdominal distension. Which of these tests will not help to know the synthetic functions of the liver? Serum albumin, serum ammonia, total bilirubin, or both B and C? Okay, so we have everyone giving different answers. We have Yash saying both B and C. We have yes, I said it saying bilirubin. Then we have someone saying ammonia. No one is able to arrive to a conclusion. Okay, so let's go and see each and every function of the liver. All of you all know functions of the liver, correct? Barabar. So serum albumin or formation of proteins of the liver. Okay, so you have formation of serum albumin, you have formation of alpha-1 acid glycoprotein, then you have clotting factors, 2, 7, 9, 10, especially vitamin K dependent clotting factors, your transport proteins, all of those are formed by the liver, correct? So this is not a, this is a synthetic function of the liver. You're forming the proteins. Now, what is serum ammonia? Serum ammonia, anyone? Yeah, so serum ammonia is nothing but excretory function of the liver. Okay, so you are converting all the urea into ammonia. So that is your excretory function of the liver. So this is not a synthetic function for sure. What about bilirubin? Your conjugation of bilirubin, and what do? You conjugate the bilirubin in the liver and then you secrete it in the bile. Okay, so this is a secretory function. You form the bilirubin, conjugated, and then you secrete it in the bile. So this is your secretory function of the bilirubin. Okay, so which is the synthetic function over here? The synthetic function is only formation of serum albumin. Both B and C is the answer over here. They are not the synthetic functions of the liver. Okay, so what are all the functions of the liver? Can anyone tell me what is the storage function of the liver? What does the liver store? Anyone? Any idea what all does this liver store? You have storage functions, then you have detoxification functions of the liver. Synthetic functions तो हमने देख लिया. Metabolic or excretory functions is formation of serum ammonia. Then you have other metabolic functions also of the liver, which you should know. Tell me all the functions. Yes, very good, Yash. So your storage, what all do you store in the liver? You store glycogen, you store vitamin A, and you store vitamin B12 in the liver. Okay. Then metabolic functions of the liver may you have carbohydrate metabolism, and you have protein metabolism, and you have lipid metabolism. Detoxification functions of the liver may you detoxify xenobiotics, okay, and also your steroid hormones and thyroid hormones. Okay, any other excretory functions of the liver may you excrete the ammonia and you also excrete some dyes. That is also possible. And then you have the secretory functions of the liver, which I told you, secretion of bilirubin. Okay, so those are all the functions of the liver. So in this chart, you have all the functions of the liver. You can study from here. All right, next question. A newborn delivered after a prolonged delivery shows pulse below 100 beats per minute, mild activity, minimal response to stimulation, slow and irregular respiration, and blue extremities. What is the APGAR score? Come on guys, 30 seconds for this. Quickly calculate the APGAR score. Yes. So this was actually a very easy question. It is not even a trick question. It's a very easy question. Why? I'll tell you why. So if you have a look at this, see how many things are given over here. They are giving you the pulse. They are giving you the activity. They are giving you the response to stimulation. They are giving you the respiration. And they are giving you the color of the extremities, okay, or the appearance of the patient. So they're giving you at least 5 things, and in all those 5 things something or the else is always present, hai na? So your minimum number of points that should be present is 5. So definitely 2, 3 and 4 is not the answer. The answer is 5. Only if any of these things were absent, then you mark it as 0 points. Otherwise you will mark everything as 1 point. So your APGAR score over here is 5. Okay. Now, how to identify APGAR score? I will give you a very easy way to identify APGAR score. First of all of you all know the mnemonic of APGAR. APGAR ka mnemonic is APGAR only. A is for activity, P is for pulse, G is for grimace, A is for appearance, and R is for respiration. Barabar? So this is your APGAR. Now, you all will say, ma'am, how to remember this? What is 0 points, 1 points, 2 points? I don't understand, ma'am. Now remember, if everything is normal, absolutely fine in the child, so if it is normal, you will give 2 points for it. Okay. So if the activity, he is completely active, you give 2 points. Then if the pulse is over 100 beats per minute, which is normal, you give 2 points. Then if there is prompt response to stimulation, you give 2 points. If the appearance is pink, that is normal, you give 2 points. And if the respiration is vigorously, he is crying and he is breathing very well, again it is 2 points. Okay. So 2 points, 2 points, 2 points if everything is normal. If anything is absent, completely absent, you will give no points to it, you will give 0 points. Okay. So if there is no activity, there is no pulse, he's absolutely floppy, he's completely cyanosed, and if the respiration is absent, then you give 0 points for each. Okay. So either things have to be normal or things have to be absent. If the things are anything in between, okay, then you don't have to think twice, just give it 1 point. Anything in between absent and normal is 1 point each. So if he's flexing the arms and legs, but he is not having complete activity, if he is having a pulse which is more than 60 but less than 100 beats per minute, if on stimulating him, he does not have absent response to stimulation, but he does not have complete response to stimulation, he is somewhere in between. If the appearance of his color or body is you're having cyanosed extremities but the rest of the body is pink, and if his respiration is not absent but it's not normal also, it's somewhere in between, it's slow and irregular, then this becomes nothing but somewhere in between. So whenever you have something somewhere in between, you give it 1 point each. So now if you look over here, his pulse is not normal, it's not above 100 beats per minute, but it's not very low also, it's not below 60 beats per minute, so you can give it 1 point. Then his activity is not vigorous, nor is it absent, there is some mild activity, so again you can give 1 point over here. Then response to stimulation, it's not like he's completely floppy, but it's not like he's very responsive, so there is some response to stimulation, again give it 1 point. Okay. Then next is slow and irregular respiration, so it's not like his respiration is absent, nor is he vigorously breathing and crying. So somewhere in between slow and irregular respiration, 1 more point. And blue extremities, they are just mentioning blue extremities, they are not telling rest of the body, so but they have specified that the whole thing is not blue, only the extremities are blue and the rest of the body is pink, so that is another point. So the answer is 5 points. Okay. All right. So the answer over here is 5 points. So it's very easy to remember the APGAR score. The only thing you need to remember is the mnemonic of APGAR. Okay. Activity, pulse, grimace, appearance, and respiration. All right. Next question. The newborn has stopped responding. Heart rate was 90 beats per minute 10 seconds ago. You have cleared the airway and you are ventilating the patient with a bag and mask. The junior pediatrician asks you when to start chest compression. You start chest compressions when the heart rate falls below 90, 75, 60 or 50 beats per minute. Akash, unfortunately, the YouTube annotated PDFs are not available because I'm teaching on the PPT format on YouTube. We cannot teach on the PDF format on YouTube. And also the annotations go away as soon as we stop the class. So on YouTube, if you all want to revise anything, you all can come back and watch this video at 1.5x the speed. Only on the special class platform, you are able to convert the entire PPT into PDF and download it as with annotations. That is actually the problem with YouTube classes because of the interface that we use. Yeah, very good. So everyone knows the answer to this. I'm very happy. So everyone knows neonatal resuscitation. So in neonatal resuscitation, you all know that you have to first start bag and masking so that you oxygenate the patient. You start looking for chest rise, and only when the heart rate goes below 60 beats per minute do you start chest compressions in the patient. Okay. So that is the very basic that you should be having of neonatal resuscitation that you guys should know. All right. Okay. Chest compression to ventilation in this child should be given at what rate? 30:2, 15:2, 5:1, 3:1. This, we are talking about neonatal resuscitation, guys. I'm not talking about normal resuscitation, normal CPR. We are talking about neonatal resuscitation. Okay, there is a lot of confusion. Many of you all are answering it as 30:2, but that is not the answer, guys. Whenever we are doing a CPR in adult or in adolescents, so we will go with 30:2 compression to ventilation ratio. Remember, in neonates, you have to do a 3:1 compression to ventilation ratio. In neonates, they basically lack oxygen because their lungs are very small. So you cannot give them only 2 breaths and then for a long time till 30 chest compressions are done, wait for those breaths to last. Okay. So they literally have no storage capacity of oxygen in the lungs. So 3:1 is the ventilation compression to ventilation ratio that we use in neonatal resuscitation. Okay. All right. Next question. How many chest compressions should be given per minute? 80, 100, 120 or 150? Okay, again, lot of different answers over here. Now, this is normal as CPR. How many chest compressions should be given per minute? What is the normal rate of chest compressions per minute? Arey, ऐसे, why is everyone giving different answers? A, B, C? Yeah, so, okay, just tell me in the chat box, in the answers, what is the normal rate of chest compressions per minute? Okay, yes, I said it. You're not exactly correct. The answer is 100 to 120 beats per minute. Okay, so it's 100 to 120 compressions per minute. So as per the ACLS guidelines, you should be giving not less than 100 but not more than 120 chest compressions per minute. Okay, so this is what you have to follow. So if you ask me how many chest compressions should be given per minute, I will go with answer of C, 120 per minute, maximum of 120 per minute. All right. Okay. Next one. A 50-year-old is admitted for subarachnoid hemorrhage. The plan is to insert a coil at the level of the ruptured aneurysm. Which of these maneuvers will not help in reducing the intracranial pressure during the procedure? Reverse Trendelenburg position, lumbar puncture, or hyperventilation? Which of these maneuvers will not help in reducing ICP? Okay. Yes, very good. So this now is a kind of a trick question. Always remember this. This is a trick question. Okay. So trick question mein kya hota hai basically? What do you mean by a trick question? Is look at the options over here. They have given you two opposing options. So they have given you Trendelenburg position and reverse Trendelenburg position. They are two opposite things, correct? So automatically you can rule out the other options. So you can say these both will not be the answer. In dono mein se one thing will be the answer. Okay, so that is the easiest thing that you can do to identify quickly what is the answer to this. Now, what is reverse Trendelenburg position? So reverse Trendelenburg means patient's head is up and the legs are going down. So in this way, the venous return to the heart will be more. The brain will be completely drained of all the blood. So you will have fallen ICP. Then in Trendelenburg position, your head is low and your legs are up. So in this position, the blood tends to move towards the brain. So if the blood tends to move towards the brain, you will have a rise in the ICP. Okay. So the answer is Trendelenburg position. It will increase the ICP instead of reducing the ICP. Okay. Next, lumbar puncture. When you do a lumbar puncture, suppose this is a patient, he is sitting like this, and you do a lumbar puncture, you put a needle over here and you drain out the CSF. If you're draining out the CSF, you're reducing the intracranial pressure. Hyperventilation. When you hyperventilate, what do? you reduce the amount of carbon dioxide because you're washing out the carbon dioxide by hyperventilation. Okay. Now, what does carbon dioxide normally do? Carbon dioxide causes cerebral vasodilation normally. So if there is cerebral vasodilation, there will be more blood going to the brain. If there's more blood going to the brain, there will be a rise in the ICP. Okay. So if you wash out all this carbon dioxide, the cerebral vessels will vasoconstrict. So there will be less blood going to the brain, and as a result of this, you will have fall in ICP. Okay, so lumbar puncture, hyperventilation, reverse Trendelenburg, all these will help in reducing the ICP. Trendelenburg position, on the other hand, will cause rise in the ICP. Okay, now can anyone tell me this lumbar puncture that we do, where do we put the lumbar puncture needle? In which space do we put the lumbar puncture needle? Like which layer do we have to put the lumbar puncture needle to drain off the CSF? To drain off the CSF, which layer do we have to put the lumbar puncture needle in? Do you put it epidurally, subdurally, subarachnoid, or epiarachnoid, or do you put it beyond the pyometer? Where do you put it exactly? Yes, very good, Nimish. So remember, your lumbar puncture is done in the subarachnoid space. Okay, your lumbar puncture is done in the subarachnoid space. There are two things whenever you want to give spinal anesthesia and when you want to do lumbar puncture. Both of these are given in the subarachnoid space. Okay. All right. Moving on to the next question. So this is the patient, and what is the IV anesthetic that you will prefer to induce this patient? So suppose this patient of subarachnoid hemorrhage, you want to take him up for clot evacuation surgery. Okay. Or there is a ruptured aneurysm. So you want to put a coil you want to put a coil over here to stop the aneurysm from bleeding any further. So for this surgery, what is your IV induction agent of choice? Propofol, thiopentone, ketamine, or etomidate? This is more of an anesthesia question. Okay, so I can see there is a lot of confusion between all of y'all. Everyone is answering different. That means no one knows anesthesia for sure. Maybe you'll know all the other subjects, but anesthesia nahi aata hai. So everyone who's mentioned thiopentone, Yash and Nimesh are the only ones who have mentioned thiopentone. That is correct. Okay. So remember, whenever you have any kind of neurosurgery, for neuroanesthesia, the agent of choice for induction will always be thiopentone. Okay. Why? Because thiopentone, first of all, it helps in reducing the intracranial pressure, and second of all, it helps in reducing the chances of seizures. Okay. So it is anti-epileptic. It is anti-epileptic in nature, so you prefer thiopentone. Okay. Alright. Now, propofol is preferred for most of the other surgeries, but why is it not preferred for neurosurgery? If you have thiopentone, it's better because propofol does not have anything to do with the seizure threshold. It does not help in solving seizures, or it does not help in reducing the chances of seizures. Okay. And etomidate is preferred for cardiac surgeries. So etomidate is one of the agents which helps in maintaining the blood pressure and the heart rate very well. So any cardiac surgery, you don't want much change in the hemodynamics, so you'll prefer to give etomidate. What is the agent that you will never use to induce this patient? What is the agent that you will avoid to induce this patient? Any idea? Agent that you will avoid to use in this patient? Very good, Nimesh. So that is ketamine. Okay. So ketamine is completely contraindicated in this case. Why? Because already there is bleeding in the brain, correct? There's subarachnoid hemorrhage, there's bleeding in the brain, so there will be a rise in the ICP. Ketamine will further cause a rise in the ICP, and ketamine is pro-seizures. It can actually cause seizures. So ketamine is something that you should avoid in this case. Alright? Okay, moving on to our next question. A 30-year-old female presents with a midline neck swelling that moves up on deglutition and tongue protrusion. What is the treatment of choice? Incision and drainage, excision, wide local excision, or excision with hyoid coring? C is the wrong answer. B is the wrong answer. Yeah. Giri Chaitanya and Meena have answered this correctly. The answer is excision with hyoid coring. So can anyone tell me what is this mass that you're seeing? Yash, very good, correct. Nimesh, very good, correct. So look at the mass. It's a midline neck swelling, correct? What all midline neck swellings do we have? We have thyroid swellings. We have any kind of hyoid swellings. Okay, so if you have any cyst of the hyoid or bursa of the hyoid, okay, then you can have lymph nodes which are swollen. So lymphadenopathy, especially your pretracheal lymph nodes, or you can have a laryngocele. Okay, all these are midline neck swellings. And there is one more midline neck swelling, that is thyroglossal cyst. Okay, now remember, all of these midline neck swellings that you have, your thyroid, hyoid, enlarged lymph nodes and laryngocele, all of these will move on deglutition. All of these will move on deglutition, okay, only. But the only one that moves on deglutition means nothing but swallowing plus tongue protrusion. Only one that moves on deglutition plus tongue protrusion, because it is attached to the base of the tongue. Okay, so your thyroglossal cyst, glossal bolte na, so it is attached to the base of the tongue. So whenever you protrude your tongue out, you look like this, this will move. Okay, so whenever on protrusion of the tongue, if this moves, that means this is nothing but thyroglossal cyst. Okay, so the treatment of thyroglossal cyst, as all of you all know, is excision with hyoid coring, and the name of that surgery is, as mentioned correctly by Nimesh, it is called as cyst trunk operation. Okay, so exam mein, this is the take home message. If they are giving you that the midline neck swelling is moving only on deglutition, then you can think of all of these. If it is moving on deglutition plus tongue protrusion, there is only one swelling that moves on tongue protrusion, and that is thyroglossal cyst. Okay. All right. Next question. A 40-year-old patient with weight of 150 kg undergoes bariatric surgery. He has been immobile since 2 years before the surgery. On post-op day 1, while going to the bathroom, he becomes acutely breathless and has to be intubated and put on mechanical ventilation. What is the most likely diagnosis? Pulmonary embolism, post-operative pneumonia, anastomotic leak, or congestive cardiac failure? Okay, very good. So all of you are correct in this. Okay. So what was the trick question over here? First of all, you have to see this is a obese patient, correct? The trick line that you had to see to answer this question correctly was he has been immobile since a long time, since 2 years. Okay. And when he becomes mobile, he gets up to go to the bathroom. When he becomes mobile, he becomes acutely breathless. And what is the reason for that? So basically, because he was immobile, he would have developed a deep vein thrombosis in his lower limb. Okay, and when he has started moving, when he has become mobile, the clot that was there in his lower limb has now traveled up from the venous system, from the lower limbs up to the heart, and then from the heart to the lungs, and that has caused nothing but pulmonary thromboembolism. Okay, so the answer over here is pulmonary thromboembolism. So for others who are saying, ma'am, it could be anastomotic leak, remember, if there is anastomotic leak, okay, because bariatric surgery may, if you are doing a Roux-en-Y bypass surgery, you can have anastomosis. So if there is anastomotic leak, that will present more with GI symptoms. So the patient will complain of pain in the abdomen, bloating of the abdomen, and not of breathlessness. Okay, congestive cardiac failure, yes, this is possible because the patient is so obese, but they would have presented with other symptoms also, like there would be pink frothy sputum in the patient, and especially this congestive cardiac failure, they would have mentioned some kind of cardiac history also of this patient, not simply just given the fact that he is only a bariatric patient. And post-operative pneumonia, it does not occur within 24 hours. Look at the day over here, it is just post-op day 1. So post-operative pneumonia takes at least 48 hours to develop. So that is also out of the picture. Okay, so your answer is suddenly if it's happening. So that is a embolus which has dislodged and it has caused a pulmonary embolism. Okay, moving on to our next question. What is the investigation of choice for the diagnosis in this patient? So, how will you diagnose the pulmonary embolism? What is the best way to diagnose it? Yes, very good. Absolutely correct. So, the answer is CT pulmonary angiography. Okay, the best way to diagnose this, you want to look whether the clot has gone into the blood vessel, correct? So, to look for the clot in the blood vessel, you have to look at the blood vessel. How do you look at the blood vessel? You have to do a pulmonary angiography for it. Okay, so that is the answer. Okay. And last question for today. 24-year-old male is brought to the casualty following a road traffic accident. He is abusing his relatives and nurses, violently flexing his limbs on painful stimulus and opening his eyes to painful stimulus. He becomes breathless and is intubated and sedated and paralyzed. Now he is not opening his eyes nor is he moving. What is his GCS? E1 VNT, VNT means he's intubated. Okay, M1, E2 VNT M4, E2 V3 M4, E2 V3 M5. Chalo, I will give you guys one full minute to calculate and tell me the GCS of this patient. Okay, so there is a confusion over here whether you have to look at the intubated wala verbal response or you have to look at the normal verbal response. Okay, so this is the trick of the question actually. Whenever we are talking about GCS, okay, Glasgow Coma Scale, remember you have to take the best response of the patient. What was the best response of the patient? Okay, so this after intubating and sedating and paralyzing him is not the best response of the patient. What was the best response of the patient? The best response was when he came to the casualty. Okay, so that is the one that you will consider whenever you're giving the GCS of the patient. Post intubation, post sedation, you cannot calculate the GCS of the patient. So what is the best eye response of the patient? What is the best eye response over here? He is opening his eyes to painful stimulus. So that becomes E2. Okay. Then what is the best verbal response that he has? Verbal responses, he is having inappropriate words. He's abusing everyone. So that is inappropriate words. So that is V3. And what is the best motor response that he's having? He's flexing his limbs on painful stimulus. Okay. So they are not giving anything about extension or they are not giving about normal movements. So it is flexion. So that is M4. Okay. So E2, V3 and M4. That is the best response of the patient. Best eye opening response, best verbal response and best motor response. So that will be the answer. Okay, clear guys? Did you understand? Alright. So we will continue with the case-based scenarios at 12 p.m. We have another class at 12 p.m. and we also have a class at 5 p.m. So we are going to be having a lot of case-based scenarios today. Now before we go, the last 5 minutes of every class, I am going to dedicate for solving your non-academic doubts. So if anyone has any non-academic doubts, like if you want to ask about anything about counseling, anything about USMLE, or if you guys want to ask about what are the opportunities in different super specialities, then you can ask me now. Last 5 minutes of every class I'm going to give to that. Bolo. Any doubts you guys have? Non-academic or how to study since the exam has been pushed, how to maintain your tempo. A lot of you have been messaging for two things. One is regarding counseling, because many of you all are thinking of taking up anesthesia, and a lot of you all have been messaging regarding, ma'am, exam postpone ho gaya, to now we are not able to study. So for those who want to ask about exam has been postponed and we are not able to study, remember that this time is so crucial, because those who had some subjects left, or some doubts to be cleared, or some fine tuning points to be done, they are at an advantage now. They are getting 1 or 2 months extra as compared, and especially the freshers are getting 1 or 2 months extra. So you have a whole new batch who has entered into the competition with you guys. So repeaters especially, you have to up your game now. You cannot sit back and say मेरा सब कुछ हो गया है, मेरा तो 10 बार revision हो चुका है. And you have to keep up with the competition, because your competition, in fact, with the postponement of the exam is increasing now. Okay. All right. Yes, Akash, after MD, DNB is for 3 years again. All right. So please make sure that you use this time for, if you all feel that your preparation is complete, come for such sessions that I am taking for all the case-based scenario sessions, image-based question session. I was taking a lot of image-based questions till yesterday on the special class platform, and now I'll be taking case-based scenario, and also give more grand tests. So we have an all India mock test that is coming up. So go for that. Give more grand tests so that you realize what exactly will be asked in the exam, where do you stand amongst your peers, because every time you feel overconfident, those grand tests will get you down to your original level and tell you whether your preparation is enough or no. And also you guys will be exposed to more and more exams. Okay. Yes, Malika, absolutely. Unacademy is useful for FMGE also. In fact, we have a batch that is going on for FMGE students. I teach anesthesia for FMGE as well. So we have this one, Focus FMGE December 2022 and Focus FMGE 2022 comprehensive batch. This one has already started and it is for the June FMGE students, and this one will, this is also going on right now, and this is a longer batch for the December FMGE students. And if you would like to join these batches, you can use my code Dr.Jhanvi Live, and that will give you a discount in your subscription. Okay. Yes, Malika, it is all online. So you can see it from wherever you are in the world. Akash, why people do DNB after MD? Is there any advantage? Okay, so this is what I have added over here to my name, MD DNB. So my actually primary degree is MD anesthesiology. If you want to do a post MD DNB, you don't have to actually work for it. You just have to give the DNB exam, theory and practical. It's just an additional degree behind your name. And in some countries like in UAE and everything, they consider DNB degree. So it's just another additional thing to add to your name. What to eat before the exam? That's a good question, Mulai. So you can eat a light breakfast and go. Obviously, don't overload yourself. Otherwise, because of the carbohydrate overload, you will feel sleepy. Also, don't go hungry, because already there will be a lot of stress and anxiety. And if you go hungry, empty stomach, you can have a lot of gastritis along with that. Also, you may not be able to use your brain completely, because there will be no glucose going to the brain. So whatever light breakfast you have, you can have on the day of your exam. Okay, one more thing I wanted to tell you guys, as we are coming closer to the exam, start changing your sleeping timetable as per the exam. Okay, so if your sleeping timetable, if your exam is from 9 to 12 in the morning, start adjusting your daily sleep timetable such that you wake up in the morning and you're absolutely fresh at around 7-8 a.m. You're ready to start your day, because you have to get used to using your brains maximum at this point in time now. All right, so I'll see you guys now for the next session at 12 o'clock on YouTube only. I will post the link of the YouTube class on this Telegram group, Let's Crack NEET PG. So hopefully see you for that class. Bye bye. Also, don't forget to leave a thumbs up at the end of the class if you liked it.